Welcome again, everybody. We're really glad to have you here. I'm going to introduce you to our wonderful moderator. She'll introduce you to our panelists. Dr. Judy Bass is an implementation science researcher with a broad background in sociology, economic development studies, and psychiatric epidemiology. She is professor and vice chair for education in the Department of Mental Health with a secondary appointment in the Center for Humanitarian Health. And I'll now turn things over to Judy, who will introduce our panelists who were honored yesterday with Johns Hopkins Alumni Association Awards.
Thank you. And again, welcome to those in the audience and those online. It is my pleasure to get to moderate this panel with alum from my own home department, as well as from the school in general. So let me start by introducing them, and then we'll have start the discussion. So Monica Guerrero Vazquez got her MPH here at Hopkins in 2018. She is the executive director of Centro Sol, the Johns Hopkins Centro for Salud and Opportunities for Latinos, leading programs that serve families in Baltimore since its founding in 2014. She's also a member of the Baltimore's Trauma-Informed Care Task Force. She is working on a multi-year strategy to inform city policies and procedures to align the best practices of trauma-informed care. And importantly, she's a compassionate and skilled advocate. Ms. Vazquez is advancing partnerships and programs that serve and support the growing Baltimore's Latino community. Next to her is Mr. Brandon Johnson, who got his MHS from the Department of Mental Health in 2012. Mr. Johnson serves as a public health advisor at the Substance Abuse Mental Health Services Administration, SAMHSA, in the Suicide Prevention Branch at the U.S. Department of Health and Human Services. He has led numerous projects aimed at specifically preventing suicide among African-American youth and manages a resource center providing suicide-specific materials, webinars, and training to prevention-focused organizations and communities. Mr. Johnson is a tireless advocate for positive mental health and suicide prevention services for youth and adults across the country, and has a vibrant Twitter account if you want to follow that as well. And finally, Dr. Adam Milam. Adam did his bachelor's, his undergraduate at Hopkins KSAS, his master's in health sciences, MHS, in 2009 from the Department of Mental Health, and his PhD in 2012 from the Department of Mental Health. He is a cardiothoracic anesthesiologist at Mayo Clinic and an associate professor of anesthesiology at Mayo Clinic School of Medicine. He also holds appointments in the Bloomberg School and as professor of practice at Arizona State University, where he is a national expert in addressing health disparities in adolescent substance abuse in neighborhoods and developing interventions to reduce adolescent exposure to violence, alcohol, tobacco, and other drugs. Throughout his career, Dr. Milam's work has focused on mentorship, community outreach, and boosting diversity in medicine. So I'm going to move around and join them and have to be part of the panel conversation. But I'm going to start up with an opening question for each of you. And the question is, going beyond the isolation and anxiety of these past few years, both COVID, racial riots, economic changes, how can the world address the lasting mental health implications of really what's been going on for not just the last few years, but for the last long period of time?
Sure. So I'm excited to be here, excited for this conversation, to be here with this amazing panel of people. I really think that these last couple of years have really just underscored a lot of the things that have been happening for decades, right? COVID-19 as challenging, as difficult as it's been, has really just exacerbated and brought to light so many disparities that we've seen even in mental health. We talk a lot about the physical side of it, the economic side of it, but there's also the mental health disparities that we see in terms of access to services, in terms of, people getting quality care, and the burden on the mental health system. There's been, thankfully, there's been a lot of people moving into wanting to get connected to mental health services, and it's shown just how fragmented the system is. We don't have enough providers. We don't have enough providers that represent the community that they're serving. And so this is some of the things that we've been seeing. And in my work, specifically working in suicide prevention, obviously there's been a lot talk about what the pandemic would mean, what the increases in race-based trauma, race-based events, hate crimes, and things that we've seen in the African American community, Asian American, Native Hawaiian, Pacific Islander community also. And as we're seeing this, it's really been something that we've been paying attention to. We've looked at the 2020 data, and we've seen suicides actually went down, but that was specifically because there was a dramatic decrease in suicides among middle-aged white males. But looking broader and looking at youth suicide, young adult suicide between the ages of about 15 to 34 all increased. And it increased specifically across many racial ethnic groups. And so this is an opportunity with all the things that we've seen and been connected to strengthen our system. Telemental health has exploded. We have to invest into that and get people access to services when they can't physically be there, and then underscoring and understanding what's happening with our young people. There's so many things that they take in, that they ingest, and many of us still kind of see them as sheltered. They have so much access to things that really can pull out some trauma that they've experienced, some other adverse childhood experiences. And so it's important for us to wrap services specifically to them, for them, to really help any type of suicidal ideation and prevent suicide attempts.
All of the above. I agree. The second leading cause of death for adolescents is suicide. I think I'm on. No? I think it's on. It's green. Yeah. Can you hear me? Yeah. Okay. Sorry. And that's really concerning. And we see the data that it's affecting everyone across the lifespan. And also, this is not a new topic, so I think we have to be very careful when we talk about the impact of COVID. It's not COVID that caused this problem. This has been historic. There are many causes and socioeconomic risks that affect these communities. And I think something that we need to be more intentional about is to find solutions for people with people. There is not a one size fits all. We say that frequently in public health, but we have to be intentional that, especially there are funders and funding organizations, to really think about, okay, how is this project including the voices of those impacted to find a solution. Over the past few years, we have been working closely with the Latino community here, and it's really eye-opening. And even though I'm an immigrant and I have been working with the Latino community for many years, it's really eye-opening to see how much engaged communities can be, marginalized communities can be on identifying the solutions that best work for them. Is it telehealth? How is it telehealth? How is it going to be more impactful and purposeful for them? So I think including the voices and conducting and using best practices for participatory action research is very important. And also working at all levels of our social ecological framework, working with the individual and being in the field, and not forgetting how much that can trigger us up and down in the policy. So if there are programs that work, how can we be better advocates as public health professionals to promote policy change, to promote policy accountability of policy implementation? So there are many things that we have learned throughout COVID, but definitely you have to keep in mind that COVID didn't cause the mental health crisis that we're seeing now. And there is data that shows us. So I think working in all those areas will be very important moving forward.
Good morning, everyone. I completely agree with everything that's been said. I think the pandemic and all recent events have shown, as Brandon said, the cracks in our system, our healthcare system and the public health system, mental health services as well. And I saw this firsthand when I was in Los Angeles at the start of the pandemic. There were about a dozen emergency shelters set up in Los Angeles to help prevent the spread of COVID-19. among the homeless population, and just different hospitals provided basic health care to the individuals at the shelters. And mental health, of course, was a common concern among their population.
I'm now talking about, what are some of the practical solutions? What are some of the programs that are promising, even if there's not full on evidence yet for them? What are some of the things that seem to be working to address the mental health of the community, of youth, of the healthcare workers? Yeah.
I think I'm being voluntold again. So I think there are a number of things that we're looking into, and I'll talk also from the SAMHSA side of things and some of the things that we're working on. So we have a grant program. We have the Garrett Lee Smith Youth Suicide Prevention Grant Program. I'm project lead over that grant program, and specifically, it's the largest suicide prevention grant program in the country. And we specifically give out grants to states, tribes, and territories to address suicide prevention of youth and young adults between the ages of 10 to 24. And in our work, and this got started in 2004, and over our work and going into some evidence, we've seen that the program itself has been effective. So if a state, tribe, or territory gets it, and it's a 5-year grant, so over when you get into year 2, year 3 of the grant, we've seen that with matched counties, there's a decrease in suicides among youth for those who are implementing Garrett Lee Smith activities within their state. And so, so we know that this is, a high level, kind of implementation strategy supports that have worked within the community. And a lot of our grants are focused on either on training and then continuity of care. So screening for youth at risk, doing suicide risk assessments, and then making sure that they're followed up with, whether they're inpatient, outpatient, in the community, making sure that there's supports around them. On a lower level, it's really been strengthening community-based organizations. Again, as you said, having people in the community that know the community, that work with the community. When we have, there's evidence-based practices, but especially in minoritized communities, there's still practice-based evidence, right? There's promising practices that are working, and we want to amplify those because they're not getting the funding. There's, again, we can talk all about the historical issues around researchers of color being able to get funding to find out, to get evidence-based practices kind of gone through the traditional cycle. And so we plan on promoting those. It'll be up sometime in the fall. And so we are looking to promote those. We want to get those resources out. And so that there's so many resources already there. So I encourage anyone to go to sprc.org, check those out, the resources that we have. But we're building resources with community, with local practitioners, really to build the evidence base so we can share solutions. We want to know what's working outside of just, what we see in the evidence too, but where are we seeing these strengths being built up in community, and having community-based organizations be able to contribute to that is something we haven't done before. And it promotes that equity piece. And so we're excited to see those type of opportunities come forward.
Yeah, thank you so much for that. It's really encouraging. And I think funding, as much as we love the work what we do, we need funding. We have to say that up front, because oftentimes we get requests of oh, you know how to do this. Can you just do it? No, I cannot just do it. So right. Funding and investment is important, and advocacy. I'm just going to highlight 2 of the things that you mentioned, Brandon, if that's okay. One is fighting stigma. When you're aware, when you're passionate about the topic, it's super easy to talk about suicide prevention, mental illness, depression, anxiety, substance use disorder. It's easy to have that conversation. But when you come, and it probably happened to all of you, when you come and talk to community members, when you talk to families who are struggling or living with someone with mental illness, it's a tough conversation. It's really difficult to have. Not long ago, we were asking about 400 individuals, Latinos here in Baltimore, about depression, their understanding of depression, resources about depression, how they see people with depression. And there is a lot of stigma. More than 3/4 of the individuals who were surveyed said that they think depression is a sign of weakness, that they will not hire someone with depression, and that potentially someone with depression could be dangerous. So I think battling and fighting stigma is super important. We don't have to forget that, as much innovative our approaches are. If we're, again, solutions with people without people, it's not going to work. So I think it's important to address that and my second point was the community approach, community-based solutions to mental illness. And by that, I don't mean just let's hire a bunch of community health workers, let's overload them with work and then forget about the clinical side. So I think there has to be an infrastructure that provides the mental health care on the clinical side, with medications when needed, with therapists where needed, with research when it's appropriate, but also work with the community members, to inform how the implementation is going to be. If we have an evidence-based program or intervention, is really the evidence applicable to the community where we're going to work? And then working with the local communities to inform that implementation, and particularly important in terms of community health workers or promotores, is being very mindful that the individuals are experts in the community, but they still need training, and we have to give that time in terms of resources. We have to give them that time of training. We have an intervention that requires 4 months of training of a community health worker. So the funding has to include those type of things, like the investment in training community health workers and the wellness and mental health care of the community health workers too. So again, comprehensive solutions, I think, could reach more and address more, and working together, I think, is important.
I'll go along with the theme of stigma. We see that a lot among healthcare workers. Healthcare workers don't want to admit that they're depressed, burnt out. And during our residency training after medical school, it's encouraged that even if you're sick, you come to the hospital. So if you're physically sick, people are coming to the hospital. So if there's some mental health symptoms, people are still coming to the hospital, still practicing, not getting the care that they need. And so a lot of the work that's been done over the last couple of years is trying to decrease that stigma and also connect people to care early on. And so a lot has been focused around reducing burnout and just connecting to services. So there's all these different hotlines for healthcare workers at specific institutions that if you're starting to have these symptoms, the fatigue, sadness and things like that, that you can connect with therapy early on. I think that's been important. And so the hospitals have really been trying to prioritize mental health and stress relief strategies. And some of those programs have been effective. Reducing hours has been probably the best intervention, which is not always feasible, especially in the midst of a pandemic. But reducing work hours, having different time. We have mental health days for nurses at Mayo, which helps out a lot. So if you're having a rough week, you can say, hey, I want this day off to focus on my, some work-life balance and things like that. So I think implementing programs like that early on, but also having a safety net, which people have talked about, just early prevention and having that safety net and connecting people with care earlier, so that we don't see, the end result. In anesthesiology, is a lot of substance abuse among providers, and we've been trying to reduce that by work hours, and again, reducing work hours and connecting people to care early and looking for signs. And we don't always see it, the signs early on, but really trying to prevent and reduce burnout has been the strategies within the hospitals.
All right, so this question, we're going to do the opposite direction so that Brandon doesn't have to answer everything first. So as alum, what are some of the experiences from your time here? And Adam, you can pull from all your time here, but what are some of the experiences and learning and practice-based experiences and community-based experiences? What are some of the things that You sort of reflecting back that you've taken, that you can see were directly related to some of the things that you did here during your degree programs.
The common theme, community-based research and involving stakeholders early on. I think as researchers, sometimes we go in with an idea already and try to, tell the community about themselves instead of working with our stakeholders. So common themes that we've talked about. And same thing with healthcare workers, taking the time to listen before we start trying to implement interventions. I think that's the key thing that I learned here that I take into my research. One of my mentors who's on my committee was Lee Bone, and that's all she does. Everything is community-based. So taking time to reflect with the community, and then after you get the research, disseminating that to the community to figure out how to translate that into interventions and strategies. I think that's the key that I learned from Bloomberg.
To me, it's been a lot of things. Some first generation immigrant and college graduate, and network has been very helpful. I feel that sometimes I'm too open to ask for help. Like I don't have remorse. I can, I'm also, my personality is like half introvert and half extrovert. So that comes. And I think networking has been one of the most amazing things from Bloomberg. I'm just seeing someone partner in suicide prevention, Brendan. That's amazing. Like the people that come here are absolutely mind-blowing. It's just sometimes it's just too much. It's amazing, like the connections. And the other thing is, I think something that I took to my work was data-informed interventions, not just for the passion or the love of the community, but really what's data telling us about what's happening. And if there is no data that is informing the interventions, then we have to go out and collect it. So I think those are the two main things that I got, but I'm still learning a lot.
Yeah, I mean, I think what both of you said really applies to me also. I think another aspect of it that I really got from Hopkins is understanding like social determinants of health and how those impact individuals' mental health and mental well-being. And when I came here, like I was really interested in violence prevention and what violence meant for mental health. And I just got taken so many different ways while I was here, and there were so many people who were like, yeah, like we've published on this, or we've done work here. And for me, like that was inspiring because I was really trying to learn that piece. Like I had my undergrad degree, but at the very end I got interested in this, and to get connected to a space where I was able to thrive with it, I think was powerful. And I think the network for sure, I definitely, I was Maryland's director of suicide and violence prevention for a little bit before I went to SAMHSA. And during that time, one of the faculty here was actually our evaluator on the grant. So we had a SAMHSA grant and she was an evaluator, Dr. Holly Wilcox. And to be able to do that, to be able to have like your former advisor come like, yeah, like I will be the evaluator for your grant, is pretty wild. And I think the last thing is just support, like how to support people. Like when I've had, things happen in my career and I'm like, oh, I'm cool, I'm excited about it. I've emailed the department, emailed Dr. Parisi, and I'm like, hey, like this happened. And to get like, oh, like we're so excited for you also, I think is so important because, we all do tough work. Like this work isn't easy. It's very heavy. And Dr. Adam, I don't know when you sleep, like, so, so it's like to do that kind of work, like it's important also to kind of like get, support and know that you have people like in your corner for sure.
You gave me my segue to the next question, which is the work we do, the research topics, the field topics, the practice activities, the collaborations. It's hard. So what are some things that you yourselves do to stay grounded, to take care of your own mental health and well-being?
I can.
I like to be in the middle.
Okay. I think for me, to be honest, it's something I'm still learning. Like I don't, I'm glad my wife's not here today because she would be like, yes, you need to do more of this. but it's something that I'm still figuring out. But you know at a certain point, like, we were talking as a group, our suicide prevention branch the other day, and we were like, in our work, we literally every day for 40 hours, 40 plus hours a week, we're talking about death and dying. Like it's a tough thing to do. And so it's really about being intentional. I'm learning to block out space in my calendar, in my work calendar, of just like, this is, work time. And no one knows what it means, but it's also me, like, I can't take any meetings, I can't take any calls. Like I have to, put some distance between myself and the work. And so figuring out what works. So it's time. I have 2 kids. So, when they want their time, I can't be on my phone, I can't be on my computer. And so like taking that time to do that. But I think it's a learning process because you're so passionate about the work. So it fuels you and you want to do more and more. And then at a certain point, your body's like, you have to stop and take a step back. So I think it's a learning process. It's something I'm definitely not the expert on this topic.
Yeah, reading a lot, I guess, about how to practice self-care. Yeah, I have anxiety myself. So I think recognizing that and being vulnerable with my team has been very helpful. Not because they do anything for me necessarily, but it's really helpful for them to know that I have anxiety and I've had rough weeks and others. Yeah, I do like being active, so I try to exercise, and I have an app where I monitor my time exercising, and I'm very proud when I work out every day. Some weeks, and then I'm like, oops, I didn't work out at all this week, and I'm not as young anymore, so so when I don't work out, for example, my body feels it, and I'm in pain, and like I have to work out. So exercise. Also being in touch with family and friends. This is everywhere in like social media and books and everything, but it really, really helps. Like, and the family is the family that you consider family, and the friends are the ones who you consider your best friends. Those have been very helpful to me because they are always there for me. So there are times that I work 60 hours a week and I just completely lose track of what's happening outside. And it only takes me a call or a text and someone is always going to respond. So friends, family, exercising, sleeping. I like eating. I love eating. I don't love cooking, but I love eating. So I like trying new recipes. Yeah, I don't know, a bunch of things. Oh, and I love dancing too. So when I dance, I'm so happy for like a few days. Yeah. It's possible, I think, working really hard and add things, like not forget that you're a human and that you need to do those human things, and that's totally fine.
Big topic. Work-life balance is a huge issue, as we all know. And my mentor, Deborah Furholden, we talk about this a lot because she runs constantly and is working 60 hours a week and the same thing. And we kind of talk about it. Like we need, better work-life balance. How do we get there? And, always raising your hand to say when someone, reaches out to you and saying yes. But Dr. Gaskins on the panel yesterday, talked about the power of saying no and having that work-life balance. And I think what Brandon said, being intentional about taking time off. And it's hard. Yeah. It's definitely hard for me trying to balance clinical work and research, and then also trying to find time for myself and my family. But it is possible, and I've been intentional about it over the last couple months, blocking off weekends, not responding to emails, not writing papers on the weekends, which was usually my time to do a lot of writing because it's impossible during the week, as you guys all know, with meetings and all. So I think for me, it has been being intentional about having that balance on the weekends and in the evenings, and then the importance of community and family as well. We formed a peer network on social media after the pandemic, a bunch of physicians, because we were all dealing with the stresses of dealing with COVID patients and how are we managing that. And so that community has helped out a lot, where we can share our stories, share our solutions for how we've gotten through difficult cases, rough days, and also spending time with family and friends. And just like Brandon said, being intentional about it and avoiding those distractions when you're making that time. So.
All right, well, I'd love to see if we can open it up to questions. both here and in the Zoom land. Here. Let's pass this around.
Thank you. This has been a really great presentation, and it's great to see you, Monica. And I just wanted to say, I listened to you say that, everyone at Hopkins is wonderful and they're superstars. And I just wanted to tell you, you are one of those people for me. I think you are a superstar and I enjoy working with you. But my question is, we talk about needing to have a diverse workforce, and I come from Frederick County in Maryland, which is predominantly white, but we are seeing an increase in the diversity, and we've been very intentional about ensuring that people know how to seek care, how to get clinical services, and we've been successful. However, I don't have clinicians that are bilingual, and we know that people want to see therapists that look like them, that understand their culture, that speak their language. And even under the best of circumstances, communication is difficult with two people that speak the same language. And so we want to stop using interpreters because you're introducing a third person into that clinical environment. You don't know if the communication is right. So it comes down to workforce recruitment. How do we encourage people to come work in rural areas and bring their cultural experiences and language to the clinical setting? It's really about developing that workforce. It's, education is expensive. Getting a clinical license takes many years. You have to go to graduate school. And so I'm struggling with this. I oversee services in the entire county, public and private. And when somebody leaves one agency, they're just going to another. So we're never gaining new people. We're just passing them around the community. Do you have any thoughts on how we could better recruit people into the field? That's a tough one, I know.
I can chime in very quickly. I don't work at a population base in terms of workforce, but something that we came across is opening opportunities. So doesn't mean that people of color or people in marginalized communities are necessarily going to know how to access those opportunities. And I think something that we need to be intentional in our work is building mentoring resources. And that's adding more work to you, but it's like mentoring helps. I have in my staff, this is a very tiny example, but can definitely be replicated. I have in my staff immigrants, and some of them are asylum seekers. And the way that we were able to identify and work with them is because I spent a lot of hours in the community, and they trust me, and then they tell me what their skills are. And that's when I see like, this is the person I need to train. It takes a long time, I agree with you, but it's definitely worth it. The other layer of, the other challenge that I found after I kind of onboard and train these individuals, because they already have skills. I just have to train them in how our system works, but they do know a lot, has been to overcome the administrative challenge in our institutions. It's very difficult to hire an asylum seeker if you have never hired one, or someone who has a temporary work permit if you have never hired one, because it's just new to the forms that you have to. So then I needed to be behind that process too, to inform the HR department about what that document exactly means, why I don't care that the document says that it expires in a year. So it takes a lot of work, and I think our HR systems are also very challenging for the communities, especially when we talk about immigrant and refugee populations. But it's possible. We just maybe try to identify some like local examples and try to replicate them at a larger population-based level.
No, that's a great question. We see that when there's concordance between gender, race, language, that communication improves, and then outcomes, compliance, adherence also improves, as well as patient satisfaction. And so I think we need to do a better job of diversifying our workforce And it's going to take decades, of course. And I think we've really just started making an effort to try to improve diversity. But I think reaching back to elementary schools, middle schools, high schools, to make sure that people have the resources and opportunities they need to be successful. And so we do like a STEM speaker series at City College, and a lot of speakers from Hopkins speak to the students and just tell them about different summer programs, tell them about their research and their work to encourage them to go into those fields. So I think if we provide those pathways and those opportunities, and then also making these places safe spaces. It's hard if you're the only one to go to a hospital or go to join a clinic, and you're the only female, you're the only minority, you're the only one first generation college, things like that. And so as we expand these spaces and diversify, I think it'll be a domino effect. But mentorship is, of course, invaluable. And so I know we all mentor those behind us. And I think if we keep doing that, we'll, diversify. But it's going to be a long process, as you all know.
Yeah, I totally agree. I would piggyback on what Adam said for sure. That mentorship piece is going to be critical, and even going into working with colleges and connecting with those who may be in the psych department and helping them to show like what impact they can have in the field, I think is important. Or even if there are, and again, it's going to take a while, but if there are ways to even remove some of those, barriers to even complete, like you talked about the financial piece, if there are scholarship opportunities to go through and matriculate and get those licensure and things like that. There may be some opportunities with telehealth, maybe with some bilingual service providers that may be helpful as well. But yeah, it's a major problem. Oh, and the Health Resources Services Administration, so HRSA is a part of HHS. They have a rural health program that I think is designed to help people and practitioners understand the importance of working with rural health. I'll have to get you more information on that, but I don't know all the ins and outs of their services, but I know that they have something there that might be able to help.
Thank you. I just want to talk about or ask about the younger community a little bit, because mental health is so important, and I see so many mental health struggles in my peers. And something that I've really noticed is that it's become so aware and so strong in our community that often I feel like it's hard to draw a line between what is the real struggles and real depression and anxiety and all these things that people have versus what almost makes people overlook it or makes a joke out of it because it's become such a bonding experience that I feel like I've seen it's almost, it feels cool or it feels good to be like everyone else and to say, I have anxiety, I have depression. And I feel like that has overlooked those people who actually really struggle with those things. So I'm going up around this a little bit, but how do you think we can help draw that line in the younger community and bring awareness while, not making a joke out of these really important things?
Yeah, I think a lot of things get socialized, and even there's the similar thing around suicide prevention where people are like, how do you know a person is really in crisis or looking for attention, those kind of things. And for me, it's always, I've been in the suicide prevention field for 9 years at this point. I can't necessarily tell if someone comes to me, saying that they're having suicidal thoughts of like, oh, they're just looking for attention. Like my training has taught me this. I never know. So you take it seriously every time and continue the conversation around, what does this look like? Like, what does depression look like? Like, what are the things that are associated with it? Like, how can, what are the signs and symptoms, and continue to educate. I think when, things happen like that, we don't have any control of what, how that happens in society. Some things just get picked up. At one point in time, smoking cigarettes was the coolest thing you could do. And now, people like it's socially just like not accepted. And so like those things kind of ebb and flow. I think it's just important for us, for those of us who are in the field, who have leadership positions, positions of influence, to continue to educate on, what does this look like? And a person who could be playing one day could be serious the next. Like they could say, like, oh, I have depression, and then realize at a certain point, like, no, like I'm really starting to, experience some things that are impairing my ability to function, on a day-to-day. So just continue to educate, but I don't think it's our job, or do we have the ability to parse out, what's socially acceptable or cool and not. So it's just continue to educate, continue to provide resources. And, the more we do that, those who need it in their time of need will know how to access it.
I think just adding to that is I agree that we need to take it seriously whenever someone talks about it, because even when you're going through that, you don't know that you're going through that either. So you may just mention that sometimes, or just wait for someone to notice. Mental illness is very complicated. Like when I have, anxiety periods, and I'm thinking of the advice that I give to my community, like seek for help and call this line or call your therapist. And it's like, I can't do it. So I think whenever that topic comes, it's talking about it, talk about it. Because I think that's how we can lose fear around the topic and be open about it, and seek for help when it's needed. I work with teenagers, and they have a lot of information like we have never had before. They have access to a lot of sources of information, and they know how to navigate them. But it's so overwhelming that you cannot process it. So when we have conversations about mental illness and self-care and things like that, they don't really know how to have the conversation. So that's when we start like kind of developing and opening the topic with them. So I think taking the topic seriously is still important. And if someone is just playing or joking around it, they will step out, and you will keep the person who's really in need of help. And also for people who struggle with mental illness, it's hard to talk about it. Like I'm talking about it here in public because I read many books and I struggled a lot for many years. I didn't know I had PTSD. I didn't know I had depression. I didn't know depression. I didn't know I had anxiety until not long ago. And with my therapist, we learned how to talk about it. I learned how to talk about it and not be ashamed or fear about it, scared about talking about it. So anyway, I think it takes a long time. So I will take it seriously regardless of how the topic comes, and you will stay with a person who really needs help at the end.
I don't have much to add to that, but I think it's on the other side of the spectrum with the stigma. Like even on social media, people are excited to show their pain, their struggle, and things like that. And so I think that's worsened things. But I think continuing the conversation, as was mentioned, and just any kind of red flag, just addressing that and continuing that conversation and trying to connect people to care early on with that first sign, I think is important. Because as everyone said, you never know. And we see it a lot with clinicians who joke about their stress and their symptoms, but don't take it seriously. And they, know how to access care. So people who don't have access to care and don't know how to access that care, it's, definitely problematic.
Okay, thank you. I had attended the Justice and Health Equity one yesterday, and I didn't get to answer or ask this question. So it's very applicable here. This is great. I'd like to get your thoughts on the intersectionality with the LGBTQ community, as well as the underserved communities and the health equity conversation that comes with that.
Yeah, I mean, I can start with it. I mean, I think for sure it's something that we have a major focus on in suicide prevention. One, there's a data equity conversation that needs to happen because we don't have good data on LGBTQ plus individuals, and that's where it starts. If we don't know what's happening, if we can't readily point to what's happening, where the trends are, again, all of us have been through these classes, how do we know where to intervene, how to intervene, what's happening, and where some of these things are. And, we're grateful for the Trevor Project, which does amazing work, especially also on the data side, because that's a major gap that we have to understand what's happening. And when we go into, suicidal ideation, or we look at the stats that we do have from the youth risk behavior surveillance data from the CDC, that they're disproportionately experiencing, adverse events and things like that. And so again, I think it goes to the point that Monica mentioned earlier of making sure that they are, individuals are included in this conversation, and that we're designing resources, prevention strategies and intervention strategies, particularly to talk about this issue. And it's important for us to do that. We had previous language in the Garrett Lee Smith grant program that mentioned LGBTQ plus individuals as at higher risk, and a previous administration removed that there, and I'll keep my words short on that. But those things happen. So it's important for us to make sure that we're including those individuals in the conversation. The best practices registry that I mentioned is going to have a section specifically designed to prevention and intervention strategies specifically for the LGBTQ plus community. That's a need that we have. We've made that decision. That's absolutely going to happen. And so continuing to do that, I think it starts with the data equity piece. It starts with making sure things are, that we have prevention and intervention strategies. And again, I know we talked about the social ecological model earlier, and it's making sure that we're understanding how what's happening in society is impacting that community. When you see, anti-LGBTQ plus legislation passed, there was a study that was done, and I can't remember the year where it was published, but I have it, so I can send it. But there's an article that looked at when there was laws that allowed for same-sex marriage, the reduction in suicidal ideation and attempts within certain communities. I think it was done in North Carolina. I don't know, Judy, if you know it, but I think it was North Carolina, but they showed again, when those laws were passed, that there was a reduction there. So the things that are happening in society are influencing individuals. And so when you see the anti-LGBTQ plus laws being passed, one could make the inference that there are adverse experiences coming from that, in places like Texas and et cetera. And so again, if we don't know, if we're not looking at the data to track on those trends, then we can't intervene. So I think half the battle is understanding how, when, those anti-trans laws happen in Texas and the things that we're seeing, we need to know how that's impacting that community, and then have resources available, prevention and intervention strategies that we know work, that are informed by that community, that we can kind of put into place.
Thank you. Thank you so much for all this very valuable, important information. I appreciate you speaking on all these topics. I work at Bloom Health Centers, which is a mental health group practice located in Maryland and now Virginia. And I was wondering, coming from your experiences with working with marginalized communities, where should we start reaching out and creating those connections, being mindful and sensitive of seeming like an outsider coming to swoop in and change things? We don't want to approach it that way. And so we're looking for ways to start that discussion.
I can just talk on the approaches that I've taken. It's really meeting with community leaders and meeting with the community to see exactly what they need, and then intervening, but not coming in with an intervention. So it's really that community needs assessment and partnering with the community instead of trying to save the community. So I think that's important. And we've done a lot around that in Baltimore around tobacco. And so we knew that tobacco was a problem in certain communities, but we didn't know why everyone was smoking, especially youth. And so we did focus groups and really listened to the community, talked to community leaders, and just brought all the stakeholders together. And I think that's the approach that I've taken that's been successful. Just bringing the stakeholders together and taking the time to listen before acting.
I think also something that has worked really well for us is partnering and be at their service. Like, what do they need from you? You are a visitor, if you want to put it that way, and you can ask them there are faith-based organizations, there are community-based organizations, grassroots groups that are doing a lot of work already, and maybe also concerned about the mission that you have. So just reach out to them. The networks, the power of networks sometimes is underestimated. It's really, really powerful. We do a lot of work in multiple neighborhoods and areas in the city. And we have been expanding with the population. So we go where the population goes. And the only way to do that, because my team is very teeny tiny, the only way to do that is with partnerships, working with the communities, working with the neighbors, the leaders, and organizations already doing work. And there might be in your conversation with them that you identify the gap together, where you can chime in and say, oh, okay, so I can do diabetes prevention, I can do tobacco prevention, I can do suicide prevention, but you have to work with them. I agree, like it's not just bring the solutions, I'm gonna do it. That doesn't work. Yeah.
Yeah, I mean, I don't know if I can add any more from what's been said, but yeah, just making those connections is going to be critical. And Monica mentioned faith-based organizations are really good way to do that also, and kind of building those connections. But yeah, I think they really said it all.
Well, thank you, everyone. Thank you for wonderful questions and thoughtful questions, and such a great panel. And as faculty, we often joke that, we get to pick the best students who get, so we get lots of applications and we get to pick the best students, and then we just ride the coattails and follow along. And we benefit also. People come in here for the education and for the collaborations and for the networks. And for us, we're generating colleagues. And it's a joy for me to be able to see, my colleagues on the stage with me here. So thank you, everybody. Thank you in particular to our three panelists. And I hope you enjoy the rest of the alumni weekend.